So I'm going to talk on flax in intumescent and Morgagnon cataracts, posterior polar cataracts, and zonulopathy. So literature has shown that femtosecond laser-assisted cataract surgery for white cataracts has no or posterior capsular tear occurred, whereas the risk factors for incomplete capsulotomy were seen in Morgagnon cataract and lens thickness. So the conclusion is the main complication of flax in white cataracts was incomplete capsulotomy, significantly associated with Morgagnon cataracts and increased lens thickness. Another study showed comparison with the conventional phacoemulsification. Flax for hard nuclear cataracts conserved phacoemulsification power, provided a significant reduction in corneal endothelial damage, and led to faster visual rehabilitation. So advantages in white cataract, it helps in fast completion of capsulotomy, which is within 1 second. It has an advantage of closed chamber. Then capsulotomy by flax, especially in fibrotic cataracts, makes it easier as it cuts the capsule over the fibrotic bands. You can see here, while doing flax, the anterior segment OCT shows fluid pockets with the black areas that you can see in the OCT. So usually when we do flax in white cataract, intumescent cataracts, the posterior capsular rhexis margin is usually not seen. So we usually skip the lens fragmentation part. So this is a case where we did flax in a white intumescent cataract. The important points here is always stain the capsule, and when you're doing the rhexis, because there are incomplete tags, do the rhexis in a guided circular fashion. So I did direct chop in this case, and the phacoemulsification was completed. Coming to flax in posterior polar cataract, study by Dr. Mahipal Sachdev has shown how flax in PPC, especially the anterior segment OCT, helps in detecting the pre-existing posterior capsular dehiscence and increases the safety in the posterior polar cataracts. So what we usually do is we keep an offset of 800 to 1000 microns away from the posterior capsular rhexis margin. There's another study by Dr. Vasavda showing a very nice femtodelineation way to enhance safety in posterior polar cataracts. So this is a case of posterior polar cataract where the anterior segment OCT showed dehiscence in the posterior capsule. So it helped us in preparing beforehand. So this is a case where rhexis was done with the femto, and my technique here was stop and chop technique. The nucleus grading was NS2 as told by Dr. Rohit. No hydrodissection or hydrodelineation is done. Cross chopping was done. So nuclear fragment was divided and eaten. So slow motion phacoemulsification should be done, avoiding any nuclear rotation, low IOP, and as there was a pre-existing PCR, the nucleus was brought into the AC, preventing any extension in the PCR. Can you switch off the light, please? So before taking out the phaco probe, always inject viscoelastic in the AC so that there is no fluctuation in the interior chamber pressure. You can see the pre-existing PCR. IOL was injected into the bag as it had not extended. Then the hyaloid phase was intact and IOL was placed in the bag. So there should be no tapping of the lens as it can lead to the extension of the PCR, and the case was completed. So coming to flax and zonulopathy, it was beautifully shown by Dr. Cyrus. So this was a case where preoperatively we could see that there was a gross difference in the ACD. It gave us an idea about zonulopathy. We did flax. So flax is a boon for zonulopathy as it helps in making capsular rhexis very easy So capsule rexes was done. Hydro dissection was done, slow hydro, and capsular hooks were used. The advantage of capsular hooks over iris hooks is as it goes up till the equator, providing a good support to the bag, acting as artificial zonules, and the case was easily done. So this is another case with a subluxated lens. Here, the advantage of flax in such cases is you can also customize your rexes according to the centration of the bag, and it makes very easy. Thank you.